a brief introduction and then you can start. So I welcome you all to another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery, Liaquat National Hospital. The idea behind these sessions is to build 3D neuroanatomy, which is very important while dealing with any neurosurgical cases or performing any neurosurgery. Today, the topic of our presentation is anterior cerebral artery. Dr. Zohaib is a fourth-year resident at Liaquat National Hospital, and he'll be talking about anterior cerebral artery. Dr. Zohaib, can you please start your presentation?
So starting from anterior cerebral artery. So anterior cerebral artery is the terminal branch of ICA. It arises from medial end of sylvian fissure, lateral to optic chiasm below the anterior perforated system. It courses anterior medially above the chiasm and below the medial olfactory striate, and join the opposite ACA by a anterior communicating artery that ascends in front of lamina terminalis, and both the A1 may not lie side by side. So going to the previous diagram, so here you can see from the ICA, ACA arises, ACA arises, and it is joined by the anterior communicating artery, and which further goes on to bifurcate into further branches of ACA. So now going ahead, so here is the for the anterior view sagittal section, and where the frontal lobe is being slightly removed. So here you can visualize the bilateral A1s. Here you can see the ICA giving the branches of A1, and here is the contralateral ICA giving the branch of A1 of the opposite side. Here they are joined by the anterior communicating artery. Here you can visualize the perforating artery, and beyond the on the origin of anterior communicating artery and A1, you can see at the bifurcation of origin, you may say, we can visualize the A2 branches being given off. So further going on, this is the trional dissection. Here you can visualize the ICA, while the which is lying above the cranial nerve 3. Medially goes the A1, and here which further goes on to the lentiform striate, giving the lentiform striate, and going on the lentiform. So okay, the A1 curves around the A2 artery curves around the genu of the corpus callosum above the lamina terminalis that passes backward above the corpus callosum, giving the cortical branches, which this further continues around the splenium and terminate in choroid plexus in the roof of third ventricle. It gives four convex curves. Basically, this ACA gives the four convex curves, which are posterior superior convex between the origin and acom aneurysm. These will be further elaborated in the diagram ahead. Anterior as it turns into the interhemispheric fissure, posterior superior at the junction of the rostrum and genu, anterior as it courses around the genu. So here you can see. So first one is here it is giving the at the junction of the anterior communicating and posterior communicating is giving the first convex curve. Then going ahead, it is when it is going into the interhemispheric, it is giving the second convex curve. Then at the superior aspect, it is giving the third convex curve, and while going behind the it is giving the fourth convex curve. So segments. ACA is divided at the ACOM in two segments: proximal, that is pre-communicating, while distal, that is post-communicating. Branches of distal ACA are exposed in approaches to cellular and chiasmatic region, third and lateral ventricle, false and parasagittal areas. So A1 and anterior communicating artery. A1 courses above the optic chiasm in 70% of cases, or nerve in 30% to join the ACOM anterior communicating artery. Those passing above the optic nerve most journey above the nerve near the chiasm. Usually the A1 length around from in between 7.8 to 18 mm. Average lies around 12.7 mm. While anterior communicating length lies around 2 to 3 mm, longer ACOM anterior communicating are commonly curved, king, or tortuous. So here you can see the junction. Basically, the both the A1s are lying side by side, not lying adjacent equally. The right A1 is lying slightly superior and above the left one. So when it is retracted, you can visualize the tortuous ACOM behind anterior communicating artery behind that. Here you can see the single perforating branch being given by the on the left side being given by the anterior communicating artery, while here is the lamina terminalis. Here is the basically optic nerve uh, cranial tube upon which they are lying. So there is the variation of the ecom anterior communicating artery. Usually it lies above the uh, lamina optic pituitary. It lies either above the optic chiasm. Here you can see, or it may lie slightly below it. As you can see, there are different variations. Whether it is above the, while in the diagram B, it lies below the optic chiasm. Here you can see it is lying slightly above. So normal ACA ACOM complex. ACOM anterior communicating artery connects A1 of nearly equal size. Both A A1s and the anterior communicating are of sufficient size to allow circulation between the carotid arteries and through the anterior circle of Willis. ACA diameter averages around 1 mm less than the average diameter of A1. A1 hyperplasia has the high rate of association with anterior communicating artery aneurysm that sums up around 85%. Direct association is also noted, that is difference in diameter between the A1s and the size of the ACOM. The difference in the diameter between the A1s, if is around zero point 0.5 or less, average ACOM diameter usually resides around 1.2. If 2.5 is the difference, if the difference is more than zero point 0.5, ACOM not oriented in a strictly transverse plane. It is usually oblique, straight anterior posterior plane, left ACA slightly anterior to right ACA, require oblique angiography. So in the as the previous diagram we saw that slightly ACA was slightly anterior as compared to the right. Variations one ACOM, basically there are, if in 60% of cases you may experience a single ACOM anterior communicating artery. There may be two anterior communicating arteries in 3% or 30% of cases, while there may be three anterior communicating artery in 10% of cases. Anterior communicating artery may be tiny, usually around as small as 0.2 mm in diameter. There may be a duplication of portion of A1. There may be third or median ACA arising from the anterior communicating artery that courses upward and backward above the corpus callosum, give branches to the paracentral lobules. So, recurrent artery of Heubner, that is the largest artery arising from the A1 or the proximal zero point 0.5 mm of the A2, may infrequently be absent on one side or arise as several branches. Diameter may be less than half of the A1, may be as large as or exceed the A1 diameter if the A1 is hypoplastic. Origin, it arises from the lateral side of the junction of A1 and A2 at right angle to the parent vessel, either in common with or with, give rise to the frontopolar artery. It courses anterior or superior to A1, usually seen on elevating the frontal lobe after visualizing the A1. Also above the bifurcation and the proximal and the proximal MC in its lateral course. So here you can see. So here you can see that the recurrent artery is arising just above the junction of the A1. A1 and ACOM and just above the junction of the ACOM and A2 and A2
It is
branch.
A1. It is A1 and A2, and it
Yes, sir.
is sometimes seen before you see the A1. When you retract the frontal lobe, this is sometimes the first artery that you see, and people mostly confuse it with A1s. So you see it at the junction of A1, A2, and if you see it's running superior to A1. So when you retract the frontal lobe, this may be the first vessel that you see.
Sure, sir. So here you can visualize that it is arising. So okay. So here is the different variation of recurrent artery of Heubner. Here it is arising from the A2, while here you can see it is arising slightly beneath the junction of the A1 and A, and A1. While here you can see that it is coursing arising from the A2 junction, but running superiorly behind the A1 in the diagram C. Here you can see it is arising slightly just above the junction of the ACOM and A2 and running laterally and superiorly above the A1. Here you can see that there are arising multiple recurrent arteries. As you can see, this one arising just from the A1, while this arising from just junction above the ACOM and A2, A1 and A2. It branch into the anterior perforated system and 40% terminate medial and 40% lateral to the ACA origin, remaining to the inferior surface of the frontal lobes. Supplies uh, anterior part of caudate nucleus, anterior third of putamen, anterior part of the outer segment of the globulus pallidus, anterior inferior portion of the anterior limb of internal capsule, and uncinate fasciculus. So, it occlusion may cause hemiparesis of the facial and brachial, along with that aphasia. So you can see that basically as it is supplying the anterior part of the anterior limb of the internal capsule, so the base lower limb is being spared here. Basal perforating branches. Averages around 8 basal perforators ranging from 2 to 15 arise from each A1 lateral, uh, more from the lateral aspect than from the medial. They usually terminate in anterior perforated substance, dorsal surface of optic chiasm, nerve, optic tract, sylvian fissure, and lower surface of the frontal lobe. Anterior perforated substance medial to AI origin. Uh, Anterior perforated substance medial to the AI origin. 40% of the both AI and RAI branches, recurrent artery of Heubner branches. Anterior perforated substance lateral to the AI origin gives recurrent recurrent artery of Heubner branches. So here you can just see that you can see the frontal basilar arteries here. You can see the basilar arteries going up to the diencephalon. Further, it is retracted, pulled down. The A1 and A2 complex is pulled down, where you can see the branches going on to the going on to in front, going ahead and into the diencephalon. Basilar artery going into the diencephalon further. Here you can see the further branches. So here you can see the multiple basilar arteries as shown in the diagram A. just arising from the AC A1 bilaterally, and with different variations. This is arising from the anterior communicating artery, and this is in this diagram you can see diagram E, you can see the both arising from the anterior communicating artery, while bilateral A1s. A1 mainly supply the chiasm and anterior third ventricle and hypothalamic area. Involvement of the hypothalamic branch results in emotional changes, personality disorder, and intellectual deficits. Heubner's artery supply caudate and adjacent internal capsule. ACOM aneurysm, anterior community artery perforating arteries arise from the superior or posterior surface. Those they terminate in superior suprachiasmatic area, dorsal surface of optic chiasm, anterior perforated substance. They perfuse the fornix, corpus callosum, septal region, and anterior cingulum. So here you can see the perforating artery that is arising from the anterior communicating artery as shown in the previous diagram. When the other one is retracted, you can see the perforating artery just arising from the anterior communicating artery behind it and going into the diencephalon.
Can you zoom these diagrams? The diagrams are too small to visualize.
Mm, so,
This is a little better, and you can go to full screen. Let-
sir, now is it better?
Yes, it is better, but you should have taken care of that. The
Yeah,
slide
sure.
is so.
Uh, Basically, it's so busy. I could have done it in two. Okay, sir. So here you can visualize the anterior perforating arteries arising laterally from the A1s. Here you can further visualize they are arising anterior perforating arteries arising from lateral aspect of A1 and running into the surrounding adjacent areas. So, so previously what we were studying was the proximal part, just pre-communicating. So now we are studying the distal part, post-communicating. So distal part is further divided into A2 infra callosal segment that begins at the anterior communicating artery, passes anterior to the lamina terminalis, terminates at the junction of the rostrum and genu of the corpus callosum. A3 precallosal segment that extends around the genu of the corpus callosum, terminates where the artery turns sharply posterior above the genu. A4 supracallosal and A5 postcallosal segments located above the corpus callosum, separated by a point dissected in the lateral view behind the coronal suture, ascending A2, A3, and horizontal A4, A5 segments. So here you can see the A2 segment arising from the anterior communicating after the junction of the A1 anterior A1 and A2 junction, which further goes on to the A3 segment on lying on the head and genu. Then when it curves around, it forms the callosum marginal and A4 segment, which further goes on to the forming the A5, but uh, branch is given in the central lobule, which goes into the paracentral lobule, that is that is A5. So here it is retracted uh, slightly retracted to show the A3 and the genu of corpus callosum, and further going on to the OFO branches.
So this
So,
is an interhemispheric. This is an interhemispheric view where
yes,
you're
sir.
looking at the distal ACA.
Yes,
Okay.
sir. Yes, sir. So, pericallosal artery. ACA distal to the anterior communicating artery around the corpus callosum. Artery formed by the bifurcation near the genu of the corpus callosum into the pericallosal and callosum marginal arteries. Callosum marginal arteries variable site of origin and absent in nearly 20% of hemisphere. So here you can see that the junction pericallosal just arising, and after the A3 you can see the callosomarginal artery arising and going on to the uh, interhemispheric region. Sir, it's around sir, I've done up till here for now. So can I continue further in the next session?
What will you be discussing in the next session?
Sir, further detailing of the remaining segments of A2, and if you can say so, should I add an NGO along with that too?
So you will do another session on. So in the next session, you please start from the post communicating segment and start from A2 and go up to then finish it with an NGO. But you should have
Yes,
done the
sir.
whole thing. You should have done the whole thing in this session. But
Yeah,
it's
yes,
okay.
sir.
We'll do it next time, and
Yes.
you can start from the post communicating segment. So thank you, Dr. Zoe, for the presentation. Um, um, and we are going to continue. Basically, the issue was Dr. Zohaib actually stepped in for the presenter who fell sick, and he was kind enough to make the presentation. So that's why we cannot complete the whole presentation today. We will do the post communicating segment of A2 in the next session, and we'll show you some NGOs as well. If there's any questions, we'll be happy to take that in the chat box. If not, we would like to conclude the session. I'm sorry that this was a brief session because it was like a makeshift session where Dr. Zohaib volunteered to present since the presenter was not well. And if there is no question in the chat box, I thank you all for your participation. We'll see you all next week. We will discuss the remaining part of ACA. Thank you all for joining. Thank you, Dr. Zohaib. We will conclude the session now.
Thank you, sir, and apologies, sir.